Hey everyone, and welcome to today's Explainer. I am absolutely thrilled you're here with us. Today, we're taking on a massive goal, completely demystifying a notoriously difficult, heavily disguised disease, pancreatic cancer. We're going to unmask this silent medical challenge, breaking down exactly what it is, how it operates under the radar, and what the very latest medical knowledge actually tells us. And we're going to do it in a way that just makes sense.
Okay, let's dive into this. This one question really sits at the heart of the entire medical challenge, doesn't it? Why is this specific cancer so incredibly stealthy? Well, as you're going to see, it's basically a master of evasion. The pancreas itself is buried deep inside the body, and the cancer literally builds biological fortresses to resist standard medications. It is incredibly good at hiding.
So, to guide us through this heavy but truly fascinating topic, here is our roadmap for today. First, we'll cover the anatomy of this silent threat. Second, we'll look at symptoms and risk factors. Third, we'll explore how doctors detect this hidden cancer. Fourth, we'll break down the battle for treatment. And finally, we'll discuss the outlook and finding support.
All right, starting right off with Section 1, Anatomy of a Silent Threat. To really get this cancer, you have to understand its location. The pancreas is this crucial organ sitting deep down in your upper and middle abdomen, tucked right behind your stomach. From the outside, it is practically invisible.
Now get this, pancreatic cancer is currently the 11th most common cancer in the United States. And I know, 11th might not sound like a crazy high number at first glance, but the reality of its impact is uniquely severe.
Because the truth is, this disease is incredibly aggressive. In fact, medical projections show it is on track to become the second most common cause of cancer-related deaths by the year 2030. Think about that for a second. That is a stark, sobering projection, and it absolutely underscores the urgency of understanding exactly how this disease works so we can fight it better.
But here's a key detail. Not all pancreatic cancers are the exact same thing. Over 9 out of 10 cases are something called adenocarcinoma. It forms in the exocrine cells, and frankly, it's highly aggressive. When you hear people talking about pancreatic cancer, this is almost always what they mean. On the flip side, you have neuroendocrine tumors, or PNETs. These are rare, generally way less aggressive, and can even be benign. But for our purposes today, we're really focusing in on those aggressive adenocarcinomas. Moving right along to Section 2, Symptoms and Risk Factors. Because the pancreas is so well hidden, like we just talked about, early warning signs of this cancer are virtually non-existent.
So the crucial point is, by the time these physical symptoms actually show up, the tumor has usually already advanced and started messing with other nearby digestive organs. You might see things like pain in the upper abdomen or mid-back, jaundice, unexplained weight loss, or even a sudden new onset of diabetes. And that happens because the tumor is actively disrupting normal bodily functions at that point.
Let's talk about what actually puts someone at risk, starting with genetics. About 1 in 10 cases are linked to genes inherited from a biological parent. We also see higher risks for males and people of Black or Ashkenazi Jewish descent. Hereditary syndromes like BRCA1 and BRCA2 absolutely play a role here too. But what's really fascinating to note is that whether it's inherited or developed over time, experts find that over 9 out of 10 of all cases involve an error in a specific gene called the KRAS gene. It's a huge piece of the puzzle.
Now, let's look at lifestyle factors, because this builds on your personal risk profile. Most diagnosed individuals are over 60, but here's exactly where you have power. You can't change your genetics or your age, right? But you can control several major risk factors. Choosing not to smoke tobacco and managing your weight, especially keeping excess weight away from the waistline, are 2 incredibly effective things you can do to lower your risk.
Section 3, Detecting the Hidden Cancer. Like we discussed, your standard routine exams just aren't going to catch this. A doctor can't simply feel a lump during a physical checkup because the organ is just buried way too deep beneath everything else.
Because of that, doctors rely on a very specific, logical sequence to hunt it down. Step 1 is imaging, usually starting with a CT scan, an MRI, or an endoscopic ultrasound. Step 2 involves blood tests, specifically looking for elevated levels of CA19-9. That's a substance actually released by cancer cells right in the pancreas. Step 3 is a biopsy to remove and test a sample of the tumor itself. And Step 4 is genetic testing to find those specific gene mutations we mentioned, which helps doctors figure out exactly which targeted treatments might work best.
And this brilliantly illustrates why the staging process is so absolutely critical. It directly dictates a patient's options. If the tumor is resectable, meaning it's confined entirely to the pancreas, surgery is a go. If it's borderline, affecting nearby vessels, surgery might still be an option. But once it hits locally advanced, involving major blood vessels, or becomes metastatic, where it's actually spread to the liver or lungs, surgical removal is sadly no longer a viable option.
Which perfectly sets up Section 4, the battle for treatment. Treating pancreatic cancer is essentially a tactical biological battle against a heavily defended target.
So, let me introduce you to the primary villain making this cancer so notoriously resistant to drugs. It's called the stroma. The stroma is this incredibly dense wall of tissue that entirely encloses the tumor. Imagine a thick fortress wall. When doctors send in chemotherapy drugs to wipe out the cancer, this stroma acts as a literal physical shield, stopping those medicines from crossing over and actually reaching the tumor cells.
Because drugs have such a hard time breaking through that stroma, surgery really is the only true cure. But it is incredibly complex because the pancreas is sitting right next to key blood vessels in the stomach. There's the Whipple procedure, which removes the widest part of the pancreas, plus parts of the intestine and gallbladder. A distal pancreatectomy removes the thinner part and usually the spleen. Or, in the most extreme cases, they perform a total pancreectomy, completely removing the organ entirely.
Now, you absolutely can't survive without a pancreas, but it comes with some immense physiological trade-offs. The pancreas's main jobs are creating insulin to manage your blood sugar and hormones to digest your food. So if a total pancreectomy is performed, the patient instantly develops diabetes. They'll need lifelong insulin shots, and they have to take enzyme pills with every single meal just to physically digest their food.
For those who can't undergo surgery, there are non-surgical weapons in the arsenal. Chemotherapy is the most common, used either on its own or to try and shrink the tumors before surgery. Radiation therapy hits it with high-energy X-rays. Targeted therapies go after the specific proteins fueling the cancer. And importantly, getting into clinical trials is highly recommended for this cancer because researchers are constantly out there testing new ways to finally break through that stubborn stromal barrier we just talked about.
Finally, we reach our last section, outlook and finding support. This is where we need to shift gears a bit and look at the grounded, emotional, and very physical realities that patients face right after receiving a diagnosis.
I want to present this number with the utmost empathy. The 5-year survival rate for pancreatic cancer is 13%. That means about 13 out of 100 people survive beyond 5 years. A massive reason this number is so low is exactly what we've been discussing. It hides. More than half of all pancreatic cancers aren't diagnosed until stage 4, when the disease has already heavily spread.
Because of that reality, palliative care is introduced. And I want to be super clear here. Many people confuse palliative care with hospice or end-of-life care. It is not the same thing. Palliative care is an immediate, active tool meant to run right alongside your treatment. Since these tumors can press on internal nerves and cause severe pain, palliative care manages that pain. It makes your patients keep their nutrition and strength up during aggressive treatments, and it connects families with much-needed emotional support.
Now, what's really interesting about this is how the historical data reframes everything. Hearing a survival rate of 13% is completely terrifying. But as our medical sources point out so clearly, those numbers are about the past. They are estimates based on old data. They simply do not account for the impact of the brand new treatments, targeted therapies, and clinical trials that are actively changing the landscape of pancreatic cancer care as we speak. Which leaves us with this final thought to ponder. We know this disease is silent. We know it hides deep within the body. So what steps can you take today to understand your own personal risks? Could you benefit from genetic counseling based on your family history? Are there lifestyle changes like quitting smoking or managing your weight that you can implement right now? Being aware is absolutely the best armor we have. Thank you so much for joining me on this explainer, and as always, keep learning.